Good morning, everyone. Today I'm going to talking about the application and limitation of LIRAD, particularly for version 2018 for CT and MRI. Why we should have LIRAD? Because radiologist's impression is usually variable from one to the another radiologist. People may use suspicious, probably in favor of, or might be, and also describe the same thing with different words, such as early wash-in and early wash-out, which is capsule or pseudo-capsule, even arterial portal shunting, THAD or THID. It's very variable. So the referring physician might have different impression or different opinion. So we need to standardize our keyword. So the LIRAD, something like BIRAD or other PIRAD, for example, try to standardize our acquisition, interpretation, and reporting, which can be used by radiologists in training or researchers. Now, LIRAD 2018 have different applications, such as using LIRAD for ultrasound, for contrast-enhanced ultrasound, and for CT and MRI diagnosis and follow-up. Today, I'm going to focus on CT MRI diagnosis. Let's have a brief history of LIRAD. It starts from 2011 and have been updated in 13, 14, 17, and 18. I tried to harmonize the AASLD guideline. Now in 2018, LIRAD has integrated into AASLD clinical practice guideline. Anticipate will be updated in every 3 to 4 years. Now we have, we have LIRAD non-radiation treatment response assessment version 2024, LIRAD CTMI radiation TRA, contrast-enhanced ultrasound LIRAD 2017, and ultrasound surveillance 2024, and contrast-enhanced ultrasound non-radiation TRA. LIRAD also detail the technique, such as how we do a multi-phase CT and how we do a multi-phase MRI using extracellular agent or using tissue-specific contrast agents such as Primovist. This is the outline. We have LIRAD 2018 core diagnosis algorithm, step-by-step, from the LIRAD TRV to LIRAD 5. But we should be careful about using LIRAD in particular patient group, such as patient high risk for HCC only, which should be adult with cirrhosis, chronic hepatitis B, or current or prior HCC, including adult liver transplantation candidate or post-transplant candidate. And the cirrhosis due to vascular disorder or congenital hepatic fibrosis should be excluded, and we cannot use LIRAD for pediatric patients. LIRAD TRV, which is a tumor in vein, can be also applied LIRAD 4 or LIRAD 5 or LIRAD M to make diagnosis like LIRAD TRV due to non-HCC malignancy or due to HCC, but have some limitation using LIRAD. For example, if patient have HCV without cirrhosis, can we use LIRAD? The answer is no at the moment. How about fatty liver disease? We have already known that a lot of fatty liver disease, about 1/3, can develop HCC without cirrhosis. But nowadays, we're still not able to use LIRAD for fatty liver disease. So the patient high-risk group should be cirrhosis, should be chronic hepatitis B, or HCC, or transplantation. So this is the inclusion criteria used for only cirrhosis, hepatitis B, or prior HCC, or liver transplant. The patient without inclusion criteria, such as hepatitis C or fatty liver disease, should not apply LIRAD for this patient group. So this is the core, and we have diagnostic category here and also treatment response here using CT or MRI. This is the diagnostic category. We have LIRAD 1 to LIRAD 5 and LIRAD TIV or LIRAD M. This is the treatment response. I'm not going to do treatment response today, and we focus on the diagnosis. The major criteria for making diagnosis of CC basically categorized here. This is the major criteria. This is non-rim arterial hyperenhancement. This is the non-peripheral washout appearance and the enhancing capsule appearance. We also include the size and the threshold growth. We should note that when we're doing EOB-MI using Primovis, the washout appearance should be limited in portal phase only. And this is the targetoid appearance. Every lesion looks like a target. And so this is a rim-like arterial phase hyperenhancement, a peripheral washout, delayed central enhancement. This is for cancer, not HCC, and they usually metastasis or cholangiocarcinoma and categorized as LIRAD-M. So we have step-by-step going through the LIRAD system. The step one we have to check the patient is at high risk for HCC. And then we go through the tumor, the imaging is okay for categorization. If any tumor event will change the hemodynamic feature, so it should be identified first. And then we go through it step by step from the benign to malignant. So this is to check the image is okay, any degradation or any technical failure. And then we check any tumor event, and the lesion is benign, such as hepatic cyst or hemangioma. Probably benign is not a bit uncertain about the benign finding. And then LIRAD-M is showing a targetoid appearance. And if not within this criteria, then we have to go to probably LIRAD-3, which is intermediate probability of malignancy. And LIRAD-4 is probably HCC. And if the lesion fit the criteria of LIRAD-5, then it should be definitely HCC. So this is the table. We have arterial phase hyperenhancement. We determine any non-rim arterial hyperenhancement is the presence here, and this is no arterial hyperenhancement. We observe the size. We measure the size. And we look at any major feature, one major feature or two major feature, and fit the table. So the arterial hyperenhancement, tumor size, and the major feature will determine which LIRAD category. So this is arterial phase hyperenhancement. This is the tumor size. This is the three major features, and how many three major features we have for this particular patient in a particular lesion. One thing should be noted is that when tumor size between 1 centimeter to 2 centimeter, and we have, if the major feature is the enhancing capsule only, then we'll categorize as LIRAD-4. If it is washout or threshold growth, then it will be LIRAD-5. And the second step is using axillary features. We have some benign feature or other malignant feature. For the benign features, such as tumor is stable for 2 years and the tumor size reduction, that is very benign. So you can downgrade the LIRAD from LIRAD-5 to LIRAD-4, for example, or to LIRAD-3. Otherwise, if the patient have malignant feature, you can upgrade to LIRAD-4, but not upgrade to LIRAD-5. So we can apply the axillary features to upgrade or downgrade our LIRAD category. Has a particular tie-breaking rules in LIRAD system. If you are not certain about the observation, you can downgrade to uncertainty. This is the definitely benign for LIRAD-1. If you are not certain about the benign feature, you can downgrade to LIRAD-2. And also, you can downgrade from LIRAD-5 to LIRAD-4 or LIRAD-4 to LIRAD-3 as well. And then you have, this is the tie-breaking rule. If unsure about the presence of TIV, for example, do not categorize as LIRAD-TIV. You can categorize as non-TIV. So you final check on your category, and then you put your diagnosis. LIRAD is not a very strict category system. It's still evolving, such as when using Primovis MI, or also called EOB-MI. Because EOB-MI, this contrast agent can uptake by OATP receptors and go into hepatocyte. And in Asian guidelines, a lot of EOB-MI application has been issued and have been published. We try to make the sensitivity higher. But because of EOB contrast agent can increase the parenchyma signal intensity, which is not the same as we use extracellular contrast agent. So the LIRAD system has restrict the washout appearance in the portal venous phase. However, in Taiwan or in Asian countries, we have a lot of patients have chronic hepatitis B. And so if the washout only can be washout pattern only in portal venous phase, and then In this particular patient, you can see the T2 high signal intensity nodule here, and as diffusion restriction. This is arterial enhancement, but not washed out in the portal venous phase, only washed out in the transitional phase. But this is still HCC, about 1 centimeter in diameter. So in order to make EOB-MRI more sensitive to making small HCC diagnosis, the Korean specialists have modified the LIRAD system. They say if the arterial phase hyperenhancement which wash out appearance in portal or delay or hepatobiliary phase, but the patient is not hemangioma or cyst or not targetoid appearance, it still can make diagnosis of definite HCC, something like LIRAD 5. By approaching using this system, the Korean guideline has improved the sensitivity from 70% to 78%, and still keep the specificity slightly downgrade from 90% to 84%. For small lesion has a similar feature. The sensitivity increased from 60% to about 80%, but the specificity downgrade from 90% to 83%. But LIRAD also have some limitation, even in patients with LIRAD 5. Here is the example. This is a 64 male with chronic hepatitis B, a definite high risk for HCC with normal alpha-fetoprotein. You can see the hyperechoic lesion in the lateral segment. And you can see the lesion have very T2 hyperintensity in the lateral segment, diffusion restriction, arterial hyperenhancement, and have a hypointensity in the hepatobiliary phase and portal venous phase. So it's a LIRAD 5 lesion. So by definition, it's a definite HCC, but after operation, the pathology report is a benign tumor, which is angiomyolipoma. So LIRAD 5 doesn't equal to 100% HCC. It still has some about 5% is not HCC, and even benign tumor, such as in this particular patient. Another patient is 55 years old male with hepatitis B and increased alpha-fetoprotein, non-symptom, but ultrasound showing a hypoechoic lesion here, also in the lateral segment. You can see the lesion with T2 hyperintensity, diffusion restriction, decreased ADC on the ADC map, and increased arterial phase hyperenhancement, wash out in portal venous phase, and also in the this is multi-hands, and also late phase is wash out appearance. So again, it's a LIRAD 5 lesion. So according to this table, you can categorize this patient as LIRAD 5 because washout appearance, although the tumor is smaller than 2 centimeter diameter. After lateral segmentectomy, this is the pathology. A lot of lymphoid cell is here, and no tumor, and also have some advanced fibrosis. The pathology diagnosis, again, is a benign, which is reactive lymphoid hyperplasia. So again, LIRAD 5 is not equal to 100% HCC. LIRAD system also provides suggestion for a specific category. So in summary, the LIRAD is built on foundational standardized lexicon technique management and reporting guideline. It's providing an algorithm for using diagnosis, surveillance, and treatment response assessment of HCC. In 2018, has integrated into the AASLD guideline. Again, LIRAD 5 is not 100% specific. Some modification can improve its sensitivity, for example, using Primovis MRI. Thank you very much for your attention.